Are you currently suffering from pain on the outside of your hip? And then we went to your doctor, you were diagnosed with something called gluteal bursitis or tendonitis, but you're frustrated because the treatments that they've given aren't really helping your pain with rest or anti-inflammation? Well, this is the video for you. In this video, we're going to show you why this really isn't a tendonitis or bursitis problem, and it's more about strengthening the tendon and reducing compression. And this is treatment that really debilitates people because they're given the wrong information, but it's really easy to fix if you just learn a little bit about what it is and how to strengthen that tendon. For those who don't know me, my name is Dr. Zach Greenwade here at Performance Sport and Spine in Seattle, Washington. And today, together, we're going to bust 9 myths about this condition to help empower you to get out of pain and back to life. Before we start busting those myths, we're going to go over some terms and some anatomy so we can be sure that we can reference that in the video and we'll know what we're talking about. So if we look at our model, we've got our lumbar spine, our low back, our pelvis, and then our ball and socket, which is the hip joint. And on the outside here, that big bone, which is about 3 to 4 inches below your waist, it's called your greater trochanter. And it's a big bone if you press on the side of your hip. Now look at this yellow ball, it's a bursa, and it goes on the outside of that hip. And bursas are like shock absorbers and they help cushion things. And then outside of that is this purple band, which we're going to call for the gluteus minimus and medius tendon, and that goes out here. What happens when you bring your leg across adduction or midline, it causes compression. And that's going to be important to understand. So this way, when we reference the terms in the video, you'll know what they are. Also, make sure to watch the end of the video after the myths, as we're going to talk about the 4 criteria to help diagnose this condition all on your own. Myth number 1, that your pain on the outside of your hip is caused from that trochanteric bursitis, or the bursa, that yellow ball we talked about. When we look about MRI or ultrasound studies of the hip, we find that the glute medius or minimus, that purple band we just talked about, is far more likely to have changes than the bursa. And those changes can cause thickening and changes to the tendon that can cause compression, which can increase your pain. Secondly, isolated bursitis is very rare. Only about 2% or 8% of people will have bursa changes without other changes to the hip joint. And then lastly, when they actually cut open that bursa, they cut open that yellow ball, there's no signs of acute inflammation. It's not red, it's not hot, there's no changes that what you think of an infection, like when you cut your skin and you see like the redness on the cut. So the takeaway here is the bursa probably is playing a minor role, but the main player is that tendon and the compression and lack of strength in it. Myth number 2, that this only happens in post-menopausal females. Now this is a classic example of saying something that's most common doesn't mean it only happens in that. It is the most common to see in that demographic, but other people can have it. Especially postpartum mothers, so people that just had babies, there's a big drop in estrogen, which can make the tendon a little bit weaker. And it's even more likely if they're runners. Some other groups are people that have hip or knee arthritis or surgeries. The changes to the hip can cause scar tissue that can cause compression. So this can happen in any age group, both females and males, not just that one group. At this point, if you know that you have this or you've learned enough or want to come back to this video later, here's a video that you can start the exercises and posture modifications to start rehabbing this condition. Myth number 3, that palpation or pressing on that greater trochanter, that big bone on the side of your hip, will diagnose this condition. Well, this turns out to be much more powerful when it's negative. What I mean by that is when you press on it, if it doesn't hurt, you can think of a big net. You haven't caught it, so it's very confident that it's not there. But if you press on it and it does hurt, there's other conditions that also cause pain there, so you can't be certain with just that. You need to combine it with 2 other tests. Those being resisted abduction, so you're testing that glute med and minimus and see if it's painful or weak. And then thirdly, a single leg stance of 30 seconds, seeing if it causes pain. If all of those are positive, there's a 99% chance that you have this condition. So this is something to help empower you and help collaborate whether you're being told good advice or bad advice. Myth number 4, that diagnosis and management of this condition can be exclusively done from imaging. Well, it turns out that imaging isn't completely accurate, and it needs to be combined with physical examination or clinical examination. What I mean by this, when we look at MRI studies of hips, people without pain, so these are asymptomatic, they have no symptoms at all, 88% of those, almost 9 out of 10, will have some changes or abnormalities in those tissues. So just because you have it doesn't mean you have to have pain. Furthermore, if you go back to our model, remember this purple band was that glute medius and minimus tendon. So people over 45 years old that don't have any pain, 50 to 88% of people will have changes on MRI in this tendon. Now it is more common in people with pain, 88 to 100%, but again, 5 to almost 9 out of 10 people will have changes to this tendon that don't have pain. So your exam has to be correlated between clinical examination and imaging. You can't just base this off an MRI alone. Myth number 5, that this is a self-limiting condition, meaning that it will just get better with a wait and see approach. Now this can be really debilitating and really decrease your function of life. And it turns out about 50% of people will see some improvement over 12 months. So that's a whole year, and that can be a really long time. And what's crazy is this is really easy to address with simple exercises and posture modifications and education. So a huge part of this video is to help you understand what to do and empower you to do those things. Don't simply just rest this. Rest is not the answer here. Myth number 6, that this is caused by muscle tightness or a tight IT band. They actually did studies where they stretch IT bands or they actually elongate the IT band, and it didn't help people's pain because this is not caused by tightness of the IT band. It's caused by compression of the tendon and bursa against the bone. Some common IT band or hip stretches that we show you here, what happens is they actually take this tendon and right where it attaches to the bone, it compresses it really hard into the bone. And one thing irritated tendons don't like is tension and compression. So when you're stretching your hip, you're actually compressing that tendon and you're gonna be super painful and it's gonna be worse. And unfortunately, most practitioners are gonna tell you to stretch this condition, and that's the last thing you can do. So many people I've helped just feel better by simply not stretching for a few days. So if you have this, do not stretch your hip. Myth number 7, that corticosteroid injections are the first line of treatment. And these are kind of great, I get it, because it's easy and it does reduce your pain in the short term. But there's 2 problems with these. Over time, these injections have been shown to damage the tendon. So if you keep getting them, 1, their effect is going to wane, and secondly, you're going to pay the price probably later in life. Secondly, that pain is supposed to change behavior to some degree. So if you have pain, it makes you want to maybe not do things or exercise. Well, if that shot takes away your pain, people are less adherent or consistent with the exercises. So first line intervention should be education and exercises, not corticosteroid injections. Myth number 8, that the clamshell is the best exercise for this condition. We actually did a whole other video over here that you can click on about why clamshells really aren't that great and often actually make your hip pain worse. And what's even more crazy is they're probably the most prescribed PT or rehab exercise out there. Everyone does do a clamshell. Well, why don't you want to do a clamshell? Well, when you think about that tendon again, as you raise your leg up, that tendon runs over that greater trochanter and it causes friction and compression. So when you just repetitively irritate that tendon, it's going to make that tendon that's causing your pain more angry. Secondly, this is just not a very tough exercise. It only uses about 13% of those muscles. It's just a very unloaded exercise. And then thirdly, it's not really functional. You're not weight bearing. Like when are you ever gonna lay on your side and just raise your leg up and down? It's much better to do exercises where your feet are on the ground. That's more functional. Myth number 9, that all tears for the gluteal tendon need surgery. And I get it. The word tear is super scary. You think of like a string that's just torn, and if you use it, you're just gonna make it worse. But what's really important here is to quantify what that tear means. Is it a 5% tear? Is it a full thickness tear? A lot of people will get tears kind of through life. And what I found even like meniscus changes is, say you're 45 years old and you're not doing much, and then you get crazy into exercise, your hip starts hurting, you go get an MRI and they say, oh, you've got a tear. Well, it's extremely likely that tear's been on there for years or decades and you just started doing way too much after doing too little for too long. Not like the tendon was perfect one day and then 3 days later the tear's there. So it's really important to quantify how much that tear is. We're going to show you some guidelines when surgery is indicated though. Surgical review may be warranted when you've had pain for more than 3 months, the Trendelenburg gait, there's trochanteric pain, and there's weakness in your abductors and a positive lag sign. Lastly, we want to go over the 4 criteria that's best to diagnose this condition. So the first one is palpation. Pressing your fingers over that greater trochanter should reduce your pain. Secondly is resisting those abductors. So some sort of test where you test the strength of those lateral hip muscles. Thirdly is the single leg test at 30 seconds. And then lastly is the fader test. So this is the test that challenges those hip structures. Each one that's positive gives you more likelihood that it's going to be this condition. If all 4 are positive, it's 99%. We hope you found this video helpful. We try to make it as least nerdy as possible. So many people get the wrong information about this condition and they suffer longer and unnecessarily. We hope you found it helpful. If you did, please like the video and subscribe to our channel, and then don't forget to check out other great videos on this subject and others.